this is something about diabetes. So what we have learned in diabetes and how should we treat? I mean, now is a cardio-diabetes. All cardiologists must learn diabetes also because almost 40% patients in our practice are having diabetes. So, I mean, each and every case we may not refer to physician. Of course, they are coming from physicians, so they are on anti-diabetic treatment. But as a cardiologist, it is our duty to learn diabetes also. So what are the learnings in last 1 or 2 decades? See, diabetes is a major killer. Question is, can we reduce the risk? See, we always, when we were students, even 30 years back, we always were telling that, okay, diabetes causes microvascular complications because this was the only complication which was getting affected by treatment. Otherwise, there was no treatment for diabetic complications. So we are trying to prevent retinopathy and neuropathy, which are not deadly. Of course, they are troublesome and can lead to even blindness. Nephropathy is a killer complication. Ultimately, almost 40-50% patients ultimately die because of renal failure. But we had no answer to macrovascular complications. Arteries are getting atherosclerotic coronary artery disease, which is accelerated by diabetes, and you ultimately get myocardial infarction, stroke, or peripheral arterial disease, leading to even gangrene and amputation. But we have forgotten this complication, which is frequent, fatal, and forgotten, that is heart failure. So heart failure, diabetes per se affects myocardium directly. I mean, it does not need that patient has coronary artery disease, myocardial infarction, and infarction leads to LV dysfunction, and then causes heart failure. Diabetes can affect heart failure directly. So basically, diabetes affects pump, pipes, and filter, which ultimately leads to heart failure, renal failure, atherosclerotic cardiovascular disease, which ultimately leads to myocardial infarction, stroke, and death. See, there are almost 500 million patients of diabetes in the world, of which 60 million patients have heart failure, 20 million people have diabetic kidney disease and CKD, and almost there are 2 million people dying every year because of diabetes complication. If somebody has diabetes, his risk of coronary artery disease is increased by 2 to 3 fold, and risk of any kind of stroke is also increased by 2 to 3 fold. So it is a deadly disease. If somebody is normal, not having diabetes, then he may live for 70, 80, 90 years of age. If he is diabetic, his lifespan is reduced by 6 years, and if he gets heart attack, then his lifespan is reduced by almost 12 years, even if he does everything nice for his diabetes management. If diabetes is not well managed, then lifespan is further reduced. We know that if we control diabetes from poor to borderline to good, your chances to get myocardial infarction and death is reduced significantly. But till 2008, we had no specific drug or treatment strategy for management of diabetes which can reduce the mortality. In fact, in ECHO trial in 2008, it showed increased mortality with intensive glucose control, which was a logical thinking that let us control glucose very strictly and then you can have better outcome. But it was paradoxically increased. Mortality was increased. So after this, all pharma companies were directed by regulatory agencies throughout the world to do cardiovascular outcome trial to prove safety and non-inferiority of any new molecule which is introduced in the market for the management of diabetes. And then new era started of cardiovascular outcome trials. It is not only in diabetes, it is there in all diseases now, especially in cardiovascular system. So we had at least 4 group of molecules which are being tried since 2008. DPP-4 inhibitors are there, GLP-1 RAs are there, SGLT2 inhibitors are there, and there are newer insulins also. Out of these 2 molecules, or 2 group of drugs, they actually proved not only safe and non-inferior to the competitors, but they actually had improved outcome. They reduced 3-point MACE of cardiovascular death, non-fatal MI, and non-fatal stroke also. So they are not only non-inferior, they are superior to the established available drugs. If we talk about cardiovascular outcome trial of DPP-4, then 3-point MACE is not reduced by any of these. Whether you give saxagliptin, elogliptin, or sitagliptin, which 3 are available, I mean, they are not, they are safe, they are not, they are non-inferior, but they are not superior at least. But in fact, with sexagliptin, actually hospitalization for heart failure was increased, so it is actually contraindicated. There was almost 30% increase in risk of heart failure hospitalization with sexagliptin. So if patient has any associated cardiovascular disease or evidence of heart failure or LV dysfunction, you should try to avoid sexagliptin. Sitagliptin in that way is safe. And then there are so many trials for SGLT2 inhibitors and GLP-1 RAs. Initially, all the trials were for secondary prevention, means patient had already established atherosclerotic cardiovascular disease, but later on, people started doing it for primary prevention only. So patient has diabetes, and then there are some risk factors for development of atherosclerotic cardiovascular disease. These risk factors were age more than 50, history of hypertension or smoking or dyslipidemia. So these were the risk factors which were considered. And we know about SGLT2 inhibitors. They actually prevent reabsorption of glucose from the proximal tubule, and thereby they causes glycosuria as well as diuresis. But that is not the only mechanism. There are so many new novel pathways by which possibly it is acting. There is reduction in sympathetic nervous system activity, there is reduction in afterload, arterial stiffness, albuminuria, everything is reduced, weight is reduced, visceral adiposity is reduced, and most importantly, intraglomerular pressure is reduced, and that actually improves the renal outcome. And ultimately, heart and kidney are totally interrelated organs. One affects other also. So if you have complication of kidney, heart is affected and vice versa. If we know about these four major molecules, empagliflozin and ertugliflozin, Vertis CV trial, they were all totally secondary prevention trials, means 100% of this patient had established cardiovascular disease. While if you think about Canvas program, 1/3 of the patient had established, one-third of the patient had no cardiovascular disease, they had only risk factors. While in declared TIMI, where dapagliflozin was used, almost 60% patient had only diabetes and risk factors, but no established disease. And established disease means either patient had coronary disease, cerebrovascular disease or stroke, or peripheral arterial disease. What was the outcome? 3-point MACE, that is death, MI and stroke. That was reduced, or there was trend towards reduction by all, but it was significant only with empagliflozin and canagliflozin in EMPARAGE outcome trial and Canvas program. DAPA actually did not reduce 3-point MACE, although it was not inferior, it was non-inferior, it was safe, and same way in Vertis CV trial, ertugliflozin, it was safe and non-inferior, but it did not prove superiority. And if you further subdivide whether patient has established cardiovascular, atherosclerotic cardiovascular disease, then you give SGLT2 inhibitors, there is benefit. But when it is given for primary prevention means patient has diabetes and risk factors only, but not established atherosclerotic cardiovascular disease, then SGLT2 inhibitors do not reduce MACE. So for primary prevention, they are still safe, non-inferior, but not superior. What about heart failure hospitalization? All are equally effective, almost massive 35 to 40% risk reduction in incidence of first heart failure or recurrent heart failure, and all molecules are equally effective, including even newer one, ertugliflozin. What about time to first renal composite outcome? Again, all four molecules are equally effective. In Vertis CV trial, actually, when you take same endpoint for renal outcome like what was there in EMPA, CANA and DAPA, then it was also equally effective. And what about absence of diabetes? If patient has heart failure and no diabetes at all, if ejection fraction is less than 40%, people tried that with dapagliflozin initially in DAPA HF trial, where 55% patient had no diabetes. In Emperor reduced trial, 50% patient had no diabetes, but they had ejection fraction less than 40%, and it was given for heart failure, not for management of diabetes. What was the outcome? Cardiovascular death and hospitalization for heart failure was reduced by almost 25%, identical for both the molecules, and first hospitalization for heart failure was reduced by 30%, again identical result with DAPA as well as EMPA. And same way, renal outcome and cardiovascular death was also reduced. So now, SGLT2 inhibitor is a fourth pillar in the management of heart failure. Each and every patient with heart failure must receive ARNI, and if patient cannot afford ARNI, he can get S inhibitor or ARB. He must get aldosterone antagonist. He must get beta blocker, and SGLT2 inhibitor is a fourth pillar. Once patient is out of acute decompensated heart failure, there is no point in waiting. Even if patient has no diabetes, you can give SGLT2 inhibitor if ejection fraction is less than 40%. It is not a step care approach. You can combine all four together. In DAPA-CKD, even in absence of diabetes, 1/3 of patients received dapagliflozin. Patient had only CKD. There was albuminuria and low GFR, and they were given dapagliflozin. Of course, 2/3 patients had diabetes also, but regardless of presence or absence of diabetes, there was benefit. If patient had diabetes, yes, benefit was there. No diabetes, even more benefit. 50% risk reduction in renal outcome. If it was a very low GFR or more than 45, less albuminuria, more albuminuria, everywhere benefit was there with dapagliflozin. So it is very good for renal protection also. So this is the summary. If you see all the trial, 4 molecules for diabetes, 3-point MACE reduced by EMPA and CANA. Cardiovascular deaths and heart failure hospitalization again reduced. Heart failure hospitalization per se is reduced by all 4. Cardiovascular death is prevented only by EMPA. Total mortality, all-cause death is prevented only by empagliflozin as far as the trials are concerned. And renal outcome, as I told you, that if you see the renal outcome endpoint, all 4 are also equally effective, 35 to 40% risk reduction in renal worsening. So, how to manage? If you want to give patient as diabetes and establish atherosclerotic cardiovascular disease, then all 3 outcome, renal, MACE, and renal outcome is better, heart failure hospitalization is there, and MACE is also reduced. When you are giving this molecule for primary prevention, means diabetes and risk factors, then renal outcome is better, heart failure hospitalization is better, but MACE is not reduced. But that is also okay, it is at least non-inferior. And why this is there? Our philosophy actually has changed. Initially, when we are treating diabetes and obesity, we are thinking about lipids, glucose, blood pressure, thrombotic tendency, and other things. So there was accelerated atherogenosis causing myocardial infarction and cerebrovascular accident. So we are concentrating diabetes and this kind of complications that, okay, reduce glucose, reduce lipid, control blood pressure. Now we are thinking something differently. Now we have got novel insight. We look at insulin, we look renal SGLT2 expression, and we look at glomerular hyperfiltration and glomerular hypertension. When you give SGLT2 inhibitors, it initially reduces GFR and it reduces glomerular pressure. How? It actually causes vasoconstrictions of afferent arterioles. So that's why renal inflow, renal hypertension is reduced. And that is how it is ultimately leads to benefit in heart failure and kidney disease. So if you want to compare side effect, I'm surprised actually. If you see still there are so many fees and I have seen DM endocrinologists, they try to avoid SGLT2 inhibitors and patients are told that you will get UTI. Actually UTI is not a problem. It is just genital mycotic infection. You keep proper hygiene, that's all. UTI is not increased significantly with SGLT2 inhibitors. Diabetic ketoacidosis can occur. We know about sick holiday aspect of this. If patient is critically ill, not eating, admitted in ICU for infection and other things, at that time you have to withdraw SGLT2 inhibitors for 2, 3, 4 days. That is okay. But benefits are tremendous. 3-point MACE, heart failure, renal failure, weight loss, reduction in blood pressure, improvement in glycemia, everything is there with SGLT2 inhibitors. It should be the drug of choice. What about shortly about GLP-RS? Potential mechanism, reduction in glucagon secretion, increase in insulin secretion from the pancreas. But there are so many other pleiotropic effects. Reduces inflammation, reduces body weight, reduces blood pressure, increase nitriuresis and diuresis. cardioprotection is there, there is favorable coagulation, platelet inhibition is there, and postprandial hyperglycemia and hyperlipidemia are also prevented. And what about 3-point MACE? Significantly reduced by liraglutide, semaglutide, albiglutide, and dulaglutide. Equally effective benefit. As far as death is concerned, semaglutide oral and liraglutide reduce the death also. It reduces myocardial infarction also, reduce stroke also. So it has more effect on atherosclerotic cardiovascular disease. SGLT2 for heart failure and renal failure, while this is more for atherosclerotic cardiovascular disease also. SGLT2 inhibitors do not reduce per se stroke and myocardial infarction per se. 3-point MACE is there, so composite outcome is better. But as far as GLP-1 RS are there, they have got more vascular effect. That molecule has more on heart failure and renal failure. So even composite renal outcome significantly improved with GLP-RS. So which to give? All guidelines now say that if you have atherosclerotic cardiovascular disease or high CV risk, SGLT2 inhibitor or GLP-1 RS should be the first line of treatment. Forget about metformin. Metformin comes second. I mean, world leaders even say that even if you don't have this risk factor, then also you may not start with metformin. Nowadays, people like McMurray or Milton Pecker or Subodh Verma, who are the key opinion leaders who have done all these trials, they believe that metformin may not be now first line of treatment even in absence of these cardiovascular risk factors. If patient has diabetes, metformin comes second line of treatment for all. So that is the concept evolving. But okay, still metformin is very cheap molecule, time-tested molecule, safe molecule, although it does not reduce mortality, but it is good. So you may start metformin. Which is preferred? If patient has cardiorenal problem, CKD or heart failure, consider SGLT2 inhibitor as the first of these two groups. If patient has more of a atherosclerotic cardiovascular disease or stroke, then consider GLP-1 RS as a first choice. Unfortunately, GLP-RS are injectable, very costly. Luckily, SGLT2 inhibitors are now generic also. DAPA is available in generic form, very cheap. So use of SGLT2 inhibitor is far more compared to GLP-RS in country like India. How to start or which to give? If you want MACE reduction, both are equally effective. If you think about heart failure, SGLT2 inhibitors win the battle. If it is renal outcome, both are equally good. I mean, both are good, but SGLT2 inhibitors have upper hand. Weight loss is far more with GLP-1 RS. Route is oral, here it is subcutaneous, but semaglutide oral is coming and that may change the scenario. And caution is required. SGLT2 inhibitors need some renal function and diuresis has to be there. So if patient has EGFR less than 20, they are not effective. Up to 20, CANA and EMPA both are tried up to 20. DAPA is tried up to 30. So if it is less than 20, you cannot give SGLT2 inhibitors because it will not effective. Recurrent mycotic infection, especially of genital area, is common. You should give that warning or hygiene measure should be explained to patient when starting. UTI can occur, but it's not that much which is publicized. If patient gets diabetic ketoacidosis, I mean, it is one of the real complications. You should keep that in mind. Peripheral vascular disease and fracture initially reported by canagliflozin actually was not seen in Credence trial, so don't have fear of that. You can give even if patient has peripheral vascular disease. GLP-RS, most common side effect is nausea and gastroparesis. It causes paresis, so patient has too much of fullness and flatulence. If patient has active gallbladder disease, he should remove gallbladder. You should go for cholecystectomy before you start GLP-RS. So this is very important point to be kept in mind. Proliferative retinopathy is there. Then also it is one of the soft contraindication. And if patient has medullary thyroid carcinoma, it should not be given. So this is the last slide possibly. The upper three are SGLT2 inhibitors, lower four are GLP-RS. If you see 3-point MACE reduced by EMPA, CANA, liraglutide and semaglutide, and of course dulaglutide, Death is reduced here. Non-fatal MI is reduced by liraglutide. Stroke is reduced by, again, GLP, not by SGLT. All-cause mortality, empagliflozin, liraglutide, and oral semaglutide. And renal outcome is good with everything. And last question, whether we can combine both these. It should be effective, but no trial has, so far randomized trial is not there. They are ongoing, and in next 2-3 years we'll have trials where both are given together in same patient. Whether it is having synergistic action or no, we don't know yet. Should be effective as far as A1C control is there, weight reduction is there, and blood pressure control is there. Of course, it will be there. But whether other hard clinical outcomes are improved or not, that we don't know. Thank you.